Surgical emergencies in pediatrics, diagnosis not to be missed. So this was a topic requested by the pediatrics to present, and I did present it before in a pediatric conference, but this is to emphasize on things that we need to concentrate and not to miss so that we don't come to morbidity. I have no conflict of interest. The presentation will go through a small introduction and then the top 10 common pediatric surgical emergencies, which is the surgical things that require a surgical intervention. I kept them in pictures and it's up to you to see what they are. So if everybody knows, Neil Armstrong once said, "Mystery creates wonder, and wonder is the basis of man's desire to understand." So you want to understand and you're thinking, what's happening? Is this a medical case or a surgical case? So this question comes to mind for family physicians because they're the first liners, the emergency doctors, pediatricians for the pediatric patients. So the first and foremost, which is the most common surgical emergency that everybody knows, is in this picture. And this is an acute appendicitis. You can see on your left-hand side, this is a laparoscopic view of an inflamed appendix. Higher up on your right is the ultrasound, which sometimes I'll tell you when is the time for us to request it, and a CT scan. Do we really need them? So appendicitis. Children will come to you as an abdominal pain, and it's a very common complaint in pediatrics. They may come with complaints that has been chronic or acute. We're talking about the acute conditions now. By history, it's very difficult sometimes to pinpoint because of the age difference. As pediatric age group do not pay attention, sometimes you see them playing, but they may have the pain, but they're distracted because of the pain. Symptoms are ignored and not appreciated sometimes by parents. It's not that they do not care about them, they do, but they see the child that they are playing. So they say, okay, they are well. On physical exam, it is again difficult because each size has its problems. And sometimes it just becomes a stereotype. Somebody sees a child, examines, everything is fine. Okay, this is just a simple upper respiratory tract infection or a UTI. Then it becomes a cascade. Supplemental diagnostic procedures which will aid us in this, there is no one perfect test. Again, we have to always emphasize that acute appendicitis is a clinical diagnosis, but sometimes we need help. So with more time and resources, diagnosis can still be inconclusive sometimes. Based upon these observational studies, the relative frequency and variability of clinical findings in infants and children that are younger than 5. Why did they study children less than 5? Because they always present to us with perforation. So they may present with abdominal pain, but not all will have it, but most will have it. So it's around 94%. Vomiting in the 80s. Guarding and examinations around 70s, but tenderness only half of them. Distension 1/3. Not all will have fever, rebound, or anorexia. So it's still going on with you to have and take a detailed history and examine well. So what are the diagnostic procedures that may help us? So you have to decide, do I really want an ultrasound or a CT for the children with suspected appendicitis? It still remains a challenge. Do I order them or do I go clinically? Most of the cases, and I say it, most of the cases you can clinically diagnose them, but there are these small number of cases that you need this help from your friends, your colleagues from radiology. It is case-by-case basis. One should consider the following 4 major goals. Number 1, you want to minimize rates of missed appendicitis. You don't want to remove a normal appendix, and you don't want to miss appendicitis to go into morbidity. You want to minimize risk from radiation exposure. Remember, CT has its radiation exposure, and it's not without its complication. We want to avoid misdiagnosis leading to a negative appendectomy. I don't want to remove a negative appendix, a normal one. Properly identify appendicitis before it perforates, because then we go into complications. From the diagnostic performance perspective, the CT is the gold standard. But we say again that the CT has a bit of exposure, but it is the highest sensitivity than ultrasound for the diagnosis of acute appendicitis in children. Again, this is just to help us if we have an equivocal diagnosis. So we don't depend, the patient comes with abdominal pain and I immediately order a CT. That is not advisable. Looking at the study that was published in 2015, you can see that the graph on the top that only 50% required shared things like ultrasound or CT. 50% were clinically diagnosed and they just went ahead and operated on them. Ultrasound is not required in all. CT was done in less than 10%. So we try not to go for radiation. Now, this is an important topic that I want to discuss, especially that I have a lot of pediatricians with me. Okay, so non-operative management of appendicitis. My professor, Dr. Fadil Al-Mahrous, said this is the new norm. Actually, it could be a new norm, but for the pediatric surgeons. Sorry, but it's not for the pediatricians. It's not for anybody other than the surgeons. Why? We will discuss now. So non-operative treatment, we'll just call it NOT. NOT of early appendicitis has been proposed, and this has been going on for more than 10 years, and in adults, more than that. May be an option in only selected children with early, number one, uncomplicated appendicitis, depending upon the caregiver preference, okay? So NOT, which is non-operative management, may be safe, effective for older children who can better describe their symptoms. Older meaning above 6 years of age. But everything has its guidelines. This is being relatively new. It has its own guidelines. Number one, the abdominal pain has to be less than 48 hours. White blood cell count less than 18,000. Enormous C-reactive protein. Again, now this is something new. I have to do a CRP, which I don't do normally in all cases of suspected appendicitis. No appendicolith present on imaging. So do I do a plain film of the abdomen? I may. Appendicular diameter less than 1.1. So here again, I need an ultrasound. I need an imaging. No preoperative concern for rupture based upon the clinical findings. Again, I have to go in the guideline for my clinical findings. So NOT may be specially appropriate in children who meet these criteria and who have comorbidities that raise the risk. If I go for appendectomy, then I will have more morbidity. It should only be performed by a surgeon with pediatric expertise. So I'm saying that surgeons, general surgeons have started it before pediatric surgeons, but both have their guidelines for this. So looking at the studies that they studied them, you can see that most of them are cohorts and they are doing them without comparison studies, but some of them have a good percentage, like the study number 5, it's 92% of success rate. But remember, they do have their criteria and selections for these cases. Coming to our center, Salmania, I have taken the privilege to get the statistics, and we do between 60 to 100 cases a year. So last statistics in 2018, we did a total of 77 cases. So that was the first of the top 10 that we see. This is the second. So the clue here is a baby, 4 weeks to 8 weeks, presents with projectile vomiting that is non-bilious. So you hear this, non-bilious, clear projectile, you would think of pyloric stenosis. So the picture on your left-hand side is the ultrasound and giving you all the measurements that you need to have them so that you reach the final diagnosis. On the right-hand side, you can see the pylorus held between my index finger where the duodenum is and the thumb and index on the other side. And it looks white other than the pink, which is the stomach. And this is called like a tumor, but it's the mass that you can feel. The surgery for it is simple. You just need to slit it, and you can see the mucosa in the slit, which is the picture below that. So how do they present? What's new? We would all know what is pyloric stenosis. So the new is younger age of presentation. They may present in an age less than 3 weeks to 3 months. It's also seen in prematurity. We had a few cases, but there are less than 10% that come above 3 months of age. And nowadays, less frequent electrolyte anomalies because the diagnosis is kept in mind, and at the back of your head, everybody, pediatrics, family physicians, emergencies. So immediately when the child has maybe one vomitus or is not dehydrated, the parents may bring them and they are more aware, and then we can operate and not delay them because most of them have less electrolyte anomalies. And the primary role here is for the ultrasound. So our colleagues, radiologists, we need them here to diagnose because most of them were not able to palpate what we call like an olive mass. Risk factors, we would always say maternal smoking, bottle feeding, antibiotics taken by mother, and we used to say that's always the first male born, not anymore. The recent literature does not go with that. Treatment, so pediatric centers, you have fewer false positive ultrasounds because there are experts. You can do them laparoscopically, lower complication rates, lower stay to the hospital, and the laparoscopic procedure will have them to start orally faster, and post-operative feeding will be commenced even maybe the same day. Pyloric stenosis, this is a line to remember, can be a medical emergency, but not a surgical emergency. So medical emergency because we need to correct all the electrolytes, and not a surgical emergency. Once the child is stable with all the electrolytes that are corrected, we go ahead and operate. How many do we do? So we have in 2011 only one, but then 13 we had 11 cases. So it's between 1 to 10 cases per year. Actually 1 per month almost, maybe by last year. Next case is the volvulus of a malrotation. And this is a dead emergency where we have to intervene, okay? So malrotation versus volvulus. So is malrotation the emergency or the volvulus is the emergency? The volvulus, of course. Most often it presents during the first few months of life, an infant with an acute onset of bilious emesis. Here we have a bilious vomiting. May be diagnosed on upper GI for other reasons. Sometimes you know that this patient has malrotation, but he or she does not have volvulus. Malrotation is a surgical urgency due to the possibility of volvulus. Volvulus is a surgical emergency. Unlike pyloric stenosis, it is not a surgical emergency. So most common condition resulting in midgut volvulus, it can have a volvulus with normal rotation, not necessarily malrotation. You can have an omphalomysenteric remnant, internal hernia that may cause a volvulus, duplication, or small bowel adhesions. These are the number of cases between 1 to 2, so they are not that common, but it is a very important surgical emergency. Number 4. So number 4, you can see if everybody remembers what is the target sign or the donut sign on ultrasound and the pseudo-kidney sign, which is intussusception. So evaluation of treatment of intussusception, you have to keep in mind that ultrasound is the gold standard here, and non-operative management is the treatment of choice, which is the pneumatic reduction. 90% success rate in all centers, especially our centers. There are no indications for antibiotics in this condition, and there are cases that are done by ultrasound reduction or fluoroscopic guidance, which is pneumatic reduction. There is still 7% chance of recurrence within the first 48 hours. We still admit them after the reduction Operative exploration warrants on second recurrence if they have more than one recurrence. There may be a pathological lead point. Recurrence after surgery is rare, but it is still possible, and post-op intussusception can occur in any surgical intervention. Emergence of ultrasound-guided reduction, they started with a hydrostatic reduction. They use saline, and they look at it and see how it gets reduced. This avoids radiation, but it has the similar risks of the pneumatic reduction. Success rate varies, but it's around 90%. Cost difference between the fluoroscopic and the ultrasound. This graph shows you how many cases we need to operate for per year for intussusception. So if we see around 100 cases of intussusception per year, we only operate on 1 to 4 of them. So not many. Now this is one of the dire emergencies. You have to have a timely diagnosis not to lose an organ. Testicular torsion. Keep that in mind. Acute scrotum, if a child comes to you, has to be kept in the differential diagnosis. It's most important, but not most common. Yes, I agree. It's not most common in all pediatric age groups, but it is the most important because you may lose an organ. The peak incidence is 13 to 16 years, and before that age, 60% is a torsion testicular appendix, 30% is only testicular torsion, and 10% epididymitis. A sudden testicular pain, there is nausea, palpation is tender, and a horizontal lie, and redness and edema. These are the things that gives you the clue for you to think of torsion. Loss of chromosteric reflex on examination, and torsion of the appendix testes is almost similar. They have tenderness, but point tenderness is at the upper pole. And the testis is less tender. Ultrasound and all nuclear blood flow may be of benefit in adolescents, but smaller children, it is difficult to perform and or interpret. So children below the age of 10, it's a bit difficult, and especially below the age of 5, ultrasound does not give you all the clue. So do not delay surgical exploration if you have a doubt. It is important to gather all relevant data, but how important are they? Your clinical is very important. Laboratory, not much. Imaging, yes, if you have a doubt, but if any doubt that this is torsion, you have to take your decision fast. There is no single clinical or imaging that is sensitive enough to rule out testicular torsion. Surgical explorations should take place in a timely manner. We have this window period of 6 hours that we can save the testis. Sometimes in pediatric age group, it's not as an adult. We may be able to save the testis even after 24 hours. It all depends on how many twists there are. So how many explorations do we do? We do between 2 to 10 per year, but not all necessitate removal of the testis. If a male, you lose a testis. In a female, you may lose an ovary if you do not act fast. So the ultrasound may give you a clue, and a laparoscopic view gives you the twist that you see. So ovarian torsion. Ultrasound has a very vital role in the examination of female with lower abdominal pain. Typically, the affected ovary is enlarged, and there are multiple immature or small follicles. Color Doppler gives a clue, and sometimes, if doubtful, MRI. How many do we do per year? Between 0 to 6. I don't know why in 2016 there were many, but we did explore them. Now coming to things that are non-specific. So kids are kids. They may ingest things. The first thing, foreign bodies that they take are coins. They are the most common thing that they ingest. And once they swallow it, we have the 4 cardinal narrowing areas in cricopharyngeus muscle, level of the aortic arch, carina, just above the diaphragm. And most of them, you can extract them, or it just passes. Once it's out of the stomach, it will pass by itself. That works for the coins. What about batteries? Batteries are a bit risky. In the esophagus, remove them. In the stomach, remove them. In the small bowel, open and remove, because they may end up with ulceration and perforation. The new kid in the block, rainbow magnets. So maybe you've heard in the news and there were warnings from other countries about these small magnets. They look like sweets and candy that are swallowed by kids. I just had recently a 1.5-year-old who swallowed them and required to be open. So possibility of them passing, it can happen. But if they are swallowed separately, there may be a perforation. And once you suspect and you have this on X-ray, you have to go and explore. But sometimes you can do it with your colleagues in GI and they may successfully remove them if they are 1 or 2, not as many as the one in this X-ray. Meckels diverticulum, everybody thinks of them. So we know the rule of 2, but in newborns and infants, they may present with obstruction. So it's still an emergency. Bleeding is the most common presentation in children, and it is painless. It's a massive bleed and requires transfusion. Bleeding due to peptic ulceration at the base of the diverticulum because of the tissues that they have. Meckels can be diagnosed with technetium scan, as shown in the picture that showed you. A pre-treatment with Zantac, cimetidine, often have to repeat scan more than once if it is not positive. But if a child is between 1 to 3 years and has 2 significant lower GI bleeds, exploration is warranted. If it's asymptomatic with no bleeds, there is no point of exploring. Those polyps usually don't need transfusion. Meckels does. How many do we do per year? Between none to 6. Inguinal hernia is a very common procedure that we do. Why is it here? Why is it an emergency? Lately, we've been having a lot of reducible hernias that they come, especially in the prematurity. So an expert has to be there to reduce this hernia, and 99% of them may be reduced. It's that 1% that you're not able to reduce. If you're unable to reduce, you have to explore. If you're able to reduce without sedation, then you give an appointment for surgical repair. If extremely difficult and reduce with sedation next day, you have to operate. You have to watch the child admit for obstructive symptoms. These are the numbers of hernias that we do. In the last 9 years that I have the numbers, we haven't done any obstructed hernia urgently, except for this year, 2020, we did 2. So it's not in the statistics. This is the last thing that I'm going to discuss today is the genital trauma. This also has to be thought of. We get called for them. A thorough history is very important to rule out child abuse, of course. Careful, detailed examination is crucial. If the child does not allow you to examine, you have to take the child under general anesthesia and involve the child protection team. The cases that we needed to take for surgery are between none, 1, or up to the 6 cases in 2018. In conclusion, I hope I haven't talked a lot. I think it's less than half an hour. In conclusion, we always advise against missing the obvious. It's not always obvious, and emphasis here is not to miss and mess. Mess meaning we don't want to end up with a morbidity and, God forbid, a mortality. The surgical emergencies in pediatrics are many, but there are few that could be missed. Awareness of these conditions is crucial to all physicians managing this age category. Take-home messages: we should always keep an open mind in pediatrics, never say impossible at any age group. Keep always the list of differential diagnoses at the back of your mind and consider that everything is possible. One last line: when in doubt, just simply refer. Thank you very much for listening, and I think